And you want standard quality, Jason, on the audio?
Do what?
It's under quality, standard is the appropriate one.
Yeah, well, I think.
So thank you.
Thank you. And thanks to Ray for coming to back me up here. He is our supervisor in our communicable disease department at the health department, and he was the lead epi for the Hepatitis A outbreak. And Mary Powell is here too, who was also instrumental on the epi side of things. She's our regional epidemiologist across the street. Thanks to everybody else from our department for coming to this talk as well. So we'll talk a little bit about Jefferson County and the hepatitis A outbreak here. Talk a little bit about things and how they've gone in Kentucky as well. I know there's been some recent news information that's been descriptive of the Kentucky experience, and then just a little bit of an update about what's going on across the country as well. I've got some learning objectives. I know you have to do that when you do an educational presentation. So we'll talk about those multi-state national trends. We'll talk about, again, what's going on in Kentucky, Jefferson County. And then we'll talk a little bit about kind of working through the risk factors for the current outbreaks, what we saw specifically in our county, and how that might be a little bit different or similar to other places in the country. And then some of the unique challenges with the outbreak investigation as well as the response. That's the big part of what we dealt with during the outbreak is, you know, we can figure out people have the disease and we know how to prevent it, but, you know, there's many challenges that come up in a community as you try to respond to that. I don't know everyone's background here. I am a medical doctor, so I usually am doing this talk with people who are healthcare providers. And they know, and some of you may know a lot about hepatitis A as well, but it's a viral infection. It is one of the hepatitis viruses, and what we have known for centuries and centuries is that this is different than other types of hepatitis. So what we saw historically is that there were these episodic jaundice epidemics that would occur. And they would either be in places of poor sanitation, like military campaigns, for example. This is a frequent thing that would happen in the military. And in 1947, McCallum defined infectious jaundice or campaign jaundice or epidemic jaundice as its own unique disease compared to those serum jaundices. So later in 1973, Purcell and Feinstein were able to separate this virus and realize that we actually had a distinct hepatitis A virus as opposed to the hepatitis B and hepatitis C viruses, those serum hepatitises that we now know exist today and we have more clearly defined. And that discovery of that particular virus allowed us to develop vaccines to combat the virus. And in 1996, the hepatitis A vaccine was FDA approved in the United States. So some interesting stuff happened after that. The Advisory Committee on Immunization Practices shortly after that vaccine was FDA approved said people who are high risk should be getting this vaccine, and that vaccine was made available to those populations very quickly. And then in 1999, the same ACIP also came out and said, you know what, we should start doing this vaccine for children in endemic states. So that recommendation came out in 1999, and as you can see, the hepatitis A virus incidence went down significantly after that. So we already had a relatively low incidence in the United States because of sanitation practices and other public health interventions, but that vaccine implementation definitely helped with that. And then in 2006, there became a universal recommendation for all children to get vaccinated against hepatitis A. Why do we care about this in regards to this outbreak, right? And like whatever G was like an interesting historical fact, but as you look, the United States, along with Western Europe and Australia, have very low prevalence of hepatitis A in general. Obviously, our prevalence in the U.S. has increased in the last couple of years with all of these outbreaks, but what that means is that we have all these kids that have been getting vaccinated. We have relatively low incidence, but now we have a very high adult susceptible population of hepatitis A. So I used my family for these pictures. I didn't want to steal someone off the internet. So I have, my dad's age group. He's way older than 60 at this point. And when he was a kid, he actually had hepatitis A, turned yellow, and the doctor told him you have hepatitis. And so he, is considered immune. He is not one of those susceptible adults. My son, who was born a couple years after the universal recommendation for hepatitis A vaccine, he's immune because he got his vaccine. But we have this age group of adults, and I'm not going to put myself on the 20s or the 60s. I'll let you guess where I might be in there, but somewhere in that age range that have not been vaccinated unless they would have had a reason to be vaccinated. Travel, some other sort of medical indication. So we have a large susceptible adult population in the United States to hepatitis A. And so kind of going through this, here is what we saw in Kentucky as far as overall with the individuals who were infected in the hepatitis A outbreak. This is the breakdown of those by age. So you see that goes along pretty darn well with our susceptible population as well. And the other thing that should be noted is that even though the recommendation was for all kids to be vaccinated against hepatitis A since 2006, Kentucky did not mandate that vaccine until October of 2000. No, they came out with a letter in October 2017, and July of 2018 was when it was required. So this school year is really the first year that vaccine's been mandated in Kentucky. So you see, 0 to 9, 10 to 19, there's still some kids that are getting the disease, and that, potentially could be because of that late mandate. The other thing that's really important about adults getting hepatitis A is that usually kids get hepatitis A before we have the vaccine, and in endemic areas, they get sick. Most of the time, you don't even know that they have hepatitis A. They could have some other sort of gastrointestinal virus. If they turn yellow, they develop jaundice, then you would be able to diagnose them. But they don't get very sick. They're running around still. They're pretty well people with hepatitis A. That is not the same for adults that get hepatitis A. Adults tend to get very sick. Their immune response tends to be robust. So what we see is a much higher hospitalization rate. We see a much higher death rate. The older you get, the worse you do with hepatitis A. So I think that's important just to kind of have that context as we go through things here. So right now, all of the blue states are those that have declared a hepatitis A outbreak in the last several years. California is still on there. Their outbreak has been declared as over, but they are still listed on CDC's website as one of those states. And here's just some breakdown of those statistics. And I think, again, kind of pointing out the older population that's being infected, the hospitalization rates are very, very high. 50% or more for almost every location that you look at that's having significant numbers of hepatitis B cases. And the death rates are higher as well. Typically, we would see very low percentage of deaths from hepatitis A because most of them who are infected are kids, but the death rates are higher in the adult population that's infected. So this is one that gets all my healthcare providers. If you've been watching the news, if you've been paying attention to this at all, you might have the answer to this, but I like to ask them, what is the most likely risk factor for these recent multi-state outbreaks? And I will tell you, C is usually what they choose. So I don't know if anybody has any other thoughts on that, but B, all right, someone's paying attention out there. So B is what we have seen with these recent outbreaks. C is what we traditionally would see in the U.S. as far as outbreaks go. So a lot of these outbreaks would be food related. We had in 2012, I think it was, pomegranates were imported to Turkey, and there was an outbreak associated with that across multiple states. Hawaii had an outbreak associated with imported scallops from the Philippines in 2016. And then we had strawberries, frozen strawberries imported from Egypt in 2016. And those are kind of things that tend to be relatively sensationalized. They get publicized across the country, and people really pay attention to that. So they glob onto hepatitis A in food. But this outbreak is a bit different, and our main contributing factors were, for us in Kentucky, primarily drug use, and then homelessness as a secondary factor as well. So obviously the opioid epidemic is a big thing. I put opioids down here, but as we know from a lot of the data collecting at the health department, opioids are not the only drugs out there right now. We're seeing a lot of heroin use, but we're also seeing a lot of meth use as well. And I don't think, and Ray, you can speak more about this, but I don't think that we were really ever able to say like there's this one particular drug that was a risk factor. It was more of the unsanitary conditions, the sharing of drugs that would be similar to sharing food that might be infected with hepatitis A. So those practices where you're transmitting the virus person to person and then ingesting it to have that fecal oral spread is really how we think that the drug use is involved with the spread. There is some idea out there that there may be some IV transmission that's possible. However, that would not account for all of it because there were many people in the outbreak that we had interviewed that did not have IV drug use, but only had drug use alone. Homelessness, obviously, sanitary conditions are a big reason why homelessness is a risk factor. Many homeless people have very poor health as well, and so they might get sicker than the average person, end up in a hospital, so they might be more likely to get diagnosed than the typical person who might be able to rebound quickly from an infection. And homelessness in the U.S. is certainly a big issue. I know there's been a lot locally on the news, a lot of efforts to try to help our homeless population. California actually had a much bigger issue with homelessness than we did here as far as the risk factor for hepatitis A. And you can see they have a darker colored state down there, meaning they have a much higher amount of homelessness. Just some numbers on who's homeless here in general, and you think, it could be a lot of people. There's a lot of veterans out there. There's families. There's still a lot of kids that are too. And these are numbers specifically. So this is Kentucky's breakdown of the overall risk factors of homelessness without any drug use in Kentucky. Only 1.6% of cases only have homelessness as a risk factor. When you look at drug use alone, 71% of people were using drugs, and that was their main risk factor. When you combine the two, that percentage of homelessness goes up some to 8.1% along with the illicit drug use. And then there were about 19% of people across the state that had no risk factors. So still a portion of people that weren't able to be identified as finding a risk factor. Locally in Jefferson County, we were able to identify 60% of our population with illicit drug use, 23%. So we have a relatively large homeless population compared to some of the rural areas of the state. And so we did have a larger percentage of reported homelessness or unstable housing. So some people might not consider themselves homeless if they weren't in a shelter or on the street, but they might not have a stable place to stay. They might be couch surfing with friends. That was also included in that definition. Other places have had outbreaks within outbreaks or other clusters. Our MSM, men who have sex with men population, was not a significantly higher number of people than we would expect, and the majority of them had risk factors like homelessness or drug use that were a part of their interview and investigation. So it wasn't that MSM was the only risk factor for the vast majority. Contact was another big risk factor. Obviously, if you've been in contact with someone with Hep A, your risk is much higher of developing the infection, and so that was a large percentage of our cases locally. And then we had about 15% of people that didn't have drug use or housing instability as a risk factor. Food employees, that was a big thing. If y'all were in Louisville during the throes of this outbreak, for us, there was a lot of news media focus on food employees, and to this day, we don't have one case of confirmed foodborne transmission in the city. So thanks to a couple of, many of our food inspectors, our teams were out there providing tons of education in the city. We'll talk a little bit later about kind of our focus on trying to get food workers vaccinated and why we might have done that. But there was significant percentage of people, but not, those were not associated with foodborne cases. And then just some other GWIS information about what did we see. So men seem to be infected more than women. 65% of our cases male in Jefferson County. And then that average age was about 30 for our population here. Our local death percentage mortality rate 1.1%. And then we had locally, again, 61% of our cases were hospitalized. Genotyping, so the CDC had us sending all of our specimens to them for genotyping, which can take some time. So probably our percentage might continue to increase. I don't know if there's any still floating out there or not. It takes us several months to get those results back, but at least 44% were linked to the other cases genotype. I think one thing that was also very evident, we talked about, older people like adults get much sicker from hepatitis A, but a large portion of our population, especially those using drugs, also had concurrent liver disease. So we had many co-infections. So some people had hepatitis A along with hepatitis B. Some people had what we called the trifecta. They had hepatitis A, B, and C, and we're not betting on horse racing, but and so there were some very, very sick people already that contracted hepatitis A on top of that. So this is just a breakdown of the numbers. The people with confirmed hepatitis B, along with their hepatitis A, was 5.5% of the population in Jefferson County. Those that had confirmed B and C was up to 5.2%. And the reason why we say up to is because we had preliminary screening for hepatitis C, but we didn't always have confirmatory test results. So we would have, we do the hepatitis C antibody screen, but we didn't have a confirmational RNA test in all of those individuals. So, so to the right there on the bottom, I've got my thing, I reduce it. So right here, we had confirmed 0.9% of individuals that definitely had A, B, and C, and then also an additional 5.2%. And then you look here, similarly with hepatitis C alone, up to 43%. So 6.3% definitely had that confirmatory test. Another 33.9%, that confirmatory test wasn't available, so they could have hep C or they could have cleared that infection. We don't know. But obviously a large number of co-infected people. I just put a couple slides here on some other states and what they've been seeing as far as their demographics and hospitalizations, again, very high. Co-infections, hepatitis C. I didn't have a breakdown of whether this was that confirmatory testing or not for them, though. 56% in West Virginia, hepatitis 10%, and then drug use similar to what we saw in Kentucky here, so high. And then their homelessness rate also relatively high as well. So, so definitely West Virginia seeing similar numbers to us as far as this goes. And then I used Illinois. They don't have a ton of cases yet, but also, high hospitalization rate, co-infection rate, and then that illicit drug use. Theirs was interesting because they did have very high MSM number. I started looking at this and getting anxiety for them, but I don't know where that will go with their number of cases. I'm going to pause here to see if anybody has any questions before I move on. A little fast and furious with this. I'm very passionate about hepatitis A, so. All right. So what did we see in Jefferson County? So Ray here is very curious, and he was doing all this research, watching what was going on across the country. And when we saw cases starting back in August of 2017, he said, uh-oh, this might be something coming our way, because I know this is going on in California, and we need to be paying attention to this. In November of 2017, we were able to declare an outbreak in the state of Kentucky because one of the cases matched the California genotype, and so we were able to connect our outbreak to theirs and declare that. December 2017, we were able to get rolling very quickly and start vaccinating the community, and also encouraged hospitals, first responders, and other people in high-risk areas to be getting their hepatitis A vaccine. It's a little bit of a slow process. We can talk a little bit about that. And then in January of 2018, we began vaccinating in our correctional facility in town. In April of 2018, we reached our threshold that we were hoping would turn the tide for us at 18,000 vaccines in our high-risk population. And then in May, we saw our peak in Jefferson County, and I'll show you a slide in a little bit that goes through that. The most recent numbers throughout the state, this is by incidence of outbreak-associated hepatitis A cases throughout the state, and you can see we're not the highest population-based number of cases. And you can see Eastern Kentucky has taken the biggest hit, and that goes a lot along with our opioid epidemic and the places that have been impacted by that. And then this goes by the distribution of the cases. So here we have one of the higher numbers of cases in the state, but obviously the incident rate is not as high because our population is bigger. And then this is the most current epi curve of the cases by MMWR. You can kind of see as that begins here. I think here you can see this time frame here is kind of where Jefferson County started to see our peak. And so as we were coming back down, I'll show you in a bit, everyone else was fine. And that's kind of what things look like when you break us out of the rest of the state for cases. We were holding our breath quite a bit right around this time here when we weren't sure if we were really seeing something that's going to go down or not. And then this is based on month for the different cases in the state of Kentucky as well. And then this is locally, the map of Louisville. I've gone across the state and across the country showing people things about hepatitis A. I don't always include this map because most people don't know what the geography of Louisville is, but one of the things to take away from this is we had cases everywhere. There wasn't a specific area that was devoid of cases. However, we did see several areas that were high risk. Portland area, one. We do see, just anecdotally, a lot of drug traffic that comes across from Indiana, and I think that may be a part of the reason that was a higher caseload there. Downtown, some of that may be false because people give us the zip code of where they live, and so if they live at a homeless shelter, which tends to be downtown, that might be why some of those cases are there. But also, we do see a lot of our homelessness downtown as well, drug use. And then, interestingly, like this corridor here, Shively area, I saw a lot of cases. Comparing that to what our police see and what we see from our syringe exchange program, there tends to be a lot of correlation with the drug activity area as well.
Are these cases all reported by healthcare providers?
Generally, yes. So I'm sure our staff from communicable disease can comment on that. This is a mandated reportable disease. However, I will say that there's some stipulations with that. So we'll actually get into that a little bit. In general, I think there's a lack of education of healthcare providers. Not everybody, for some reason, gets the memo that they're supposed to be reporting communicable diseases, and that's one thing that I've noticed that we need to improve education with healthcare providers. Because there are cases that we would get random, like we have some methods to procure lab results as well. So we might find a positive lab that was never reported to us. Often we'll get double reporting from a provider as well as from the lab system, but sometimes we find out first through the lab reporting system, even though it is reportable. So,
what percentage do you think could go unchecked?
it's a great question because especially in this population, a lot of people either are not very friendly with the healthcare community right now. They're treated poorly. The stigma is terrible. So a lot of people will not come in until they're deathly ill. If they stay at home and just suck it up, they will. Homeless population too. They're not always, seeking health care. So, I mean, my estimate is that a lot of people did. I don't know, Ray, if you have it estimated. I don't know that we were ever able to come with a ballpark of, we probably had 10% or 20% of people. But But I know there were people that we didn't catch in this situation. Yeah, that just never went to get to a healthcare provider. So, yeah.
So when you did enhanced vaccination,
Mm-hmm.
you have workforce in place, or did you have people?
We'll talk about that a little bit. Yeah, it's a challenge. It's interesting. So here, our response effort. So what we recognized early by talking to the other jurisdictions that have had outbreaks is that this was not your run-of-the-mill, let's go out and vaccinate the whole community at the Kentucky Expo Center. What we realized is that we had a very difficult to reach population that we were going to have to think creatively to reach them. So we did a lot of communications with the Homeless Coalition. We put our heads together with our syringe exchange folks, with other people in recovery centers, trying to figure out how do we reach people who are using drugs that don't want to interact with the healthcare facility or with the government for that matter. And then how do we reach the homeless population in an effective way? And it's a challenge. I mean, there's not a great way. So we vaccinated at more than 70 unique locations, homeless shelters, our syringe exchange, a big place where we were able to get a lot of vaccine out to the at-risk population, some recovery centers, and then our jail was a big help because a lot of the people in the jail, probably 70% or more, are there because of drug-related charges and or homelessness is a big issue for them. And so we knew that was definitely a big place that we needed to vaccinate. Yeah. Yes. So interestingly, it wasn't a public health emergency, and I believe that if it had, if we had named it that, then we might have been able to mandate the vaccine for people. But we were able to get a pretty high percentage of people in the jail vaccinated. There's always going to be refusals for something that's not mandatory there, but.
So was the vaccine?
Interestingly, so the CDC came out relatively quickly and said, for the outbreak purposes, we only need to do one vaccine. And part of that was in California, they had a vaccine limit. Like they didn't have enough vaccine when they were going through their outbreak. And they had to figure out who should get the vaccine. And they chose not to vaccinate more than once of that. But then the data seems to support that most people are immune for a good amount of time, many years after one vaccine alone. So we were able to kind of reduce our resource suckage from by only vaccinating once and say this is what you need, and then if we're able to get you a vaccine, we will. But that we might not have those capabilities.
Right.
Yeah.
The answer is in the state.
I hope so. It looks that way to us too, but yeah, I'm hopeful for them. Honestly, I think it's just, to me, it seems like penetrance. When I talk to people from California, one of the things they said is, you know what, you're going to be dealing with this for 2 years, so you may as well just hold your breath and wait for it to happen. And I was like, we will not be dealing with this in Jefferson County for 2 years. But, just knowing that, like the natural history of the disease and the spread of the disease is that 1 to 2 years, 18 months to 2 years is really kind of what they've seen in a lot of major outbreaks in other places. So, so the time frame has not surprised me at all. And and then they have their own challenges. So I put up here urban, suburban versus rural, right? Like we had a lot of mechanisms in place to reach the populations, even though they were still difficult to reach. I imagine in rural areas, they don't have a lot of the resources we do. Many places didn't have syringe exchanges or still might not. And so we had mechanisms to reach the at-risk populations that just don't exist out there. We have resources. Even though our health department doesn't have a ton of health services anymore, we have a lot more community resources that we were able to negotiate and help use their resources. So, for example, healthcare settings, like we were able to talk to all the hospital systems and say, hey, like we're going to be vaccinating these high-risk people, but we need you to vaccinate everybody else who isn't in the high-risk group. If they come to you for a vaccine, give it to them by all means, because we do want to try to boost that herd immunity, but we are not going to be able to do that with the resources that we have at the health department, so we need to focus our efforts on those really at risk. The other one I mentioned before with the food workers, and Dr. Carrico had come to me early in the outbreak and said, I wish there was a way that we could help. Let me know what we can do. And as we put our heads together, we recognized that our food service workers fell into a high-risk group many times, and they often did not have insurance, didn't have access to healthcare. And so we thought, why don't we try to get reasonably priced vaccine to these individuals and use their companies to say, you know, boy, like we're seeing all this hepatitis A, we've seen a ton of the cases in food workers. Do you want your restaurant to be the next one that that is going to be on the news? And they did not, and so they were very motivated, and we were able to, with a grant from one of the Medicaid MCOs, we were able to get some funding to try to help reduce the cost of the vaccine for them. So that was really helpful because, one, it kind of helped with that food worker fear, but then it also really helped us get to a high-risk population that might not have been identified or reached otherwise. So healthcare, the homeless service providers, they were very cooperative. They wanted us there. They were happy to help us get in and get their population vaccinated. Correctional facilities, they were also motivated because they did not want to be the ones that had an inmate die on their watch, right? They were like, boy, yeah, really, that would be bad press for us, so we want to be involved in it. So they had a lot of high motivation early on in the outbreak. And then healthcare settings were actually, interestingly, one of the hardest groups to pull along with us, and they want data, right? They want, what is the evidence basis that you're telling me I should vaccinate my healthcare providers? And there's not a ton out there. We were able to put our heads together and find some European data that talked about attack rates in healthcare workers, and nurses tend to be the biggest recipients of hepatitis A from their patients, and probably just because they have repeated interactions. But we hadn't dealt with an outbreak where we had hundreds of patients in one hospital system with hepatitis A in the past. So this was a new thing to everyone, and I think common sense did end up prevailing in the end, but it definitely took some cajoling and discussions of risk-benefit and workman's comp costs and stuff. Like, if you get an employee that gets infected by a patient, that's going to be really expensive. So if we could vaccinate everyone, that would save you one of those cases. So just trying to do some of that cost-benefit reasoning without really having proof in the pudding of this happening somewhere else. So, and then diagnosis, you had asked about healthcare providers, some challenges. Interestingly, as this outbreak started in Louisville, we had influenza, it was the flu season. It was also a gastroenteritis season. And a lot of these individuals are taking opioids, so they have withdrawal symptoms if they go into the hospital, which all look very similar to hepatitis A until you get jaundice. So a lot of people are coming into the hospital, not getting diagnosed, going home, and coming back, a few days later when they turned yellow, and then the answer was more obvious than of what was going on. And then many providers were ordering the wrong tests. So the diagnostic criteria for Hep A is an IgM, that acute antibody level, and we would get back IgG levels, or they would say, oh, I don't know what's going on with this patient, and we just would not get accurate information about the diagnosis. So that was a challenge. And then we had some challenging clinical cases too. So when people start getting vaccinated in the community, but then they develop symptoms that are similar to Hep A, that becomes confusing. We had a lot of patients who had hepatitis A diagnosed, and then they would be sick for a really long time, or they would have their symptoms would go away, and then they'd get sick again. They'd have those recurrent symptoms. And so those were just really big challenges for our infectious disease doctors and our gastroenterologists who were taking care of these patients in the hospital. And interestingly, I do not have the credentials that they do, but they would turn to me a lot of times and say, well, what do you make of this? So, and there were some cases where we would have kind of questionable symptoms or questionable results on the lab test that we just didn't know if the individuals had hepatitis A or not. We could send off genotyping tests to the CDC, but those tests would take months to come back, so it wasn't something we could act on clinically. So our Dr. Wolf, our lab director, was able to develop PCR testing locally so that for these kind of rare cases that would come up, we were able to give at least an impression from an infectious disease standpoint of, boy, this person needs to remain out of the healthcare setting. They shouldn't be working as a healthcare worker. They shouldn't be a server right now. They shouldn't be put into a jail cell with 20 other people because they might still be infectious. So we were able to kind of tease out some of those diagnostic challenges with that PCR. And then again, this kind of goes back to there's just a lot of really sick people. So pulmonary hepatic failure is relatively common, especially in those older patients. So that was something that our gastroenterologist saw a lot of. And then community, I've talked a lot about some of these things already, so that difficult to engage population. Homeless are sometimes hard to reach, not as hard for us during this. And then especially the population who are using drugs, who might be afraid of the government, who haven't had great opportunities or experiences with the healthcare system, the stigma, makes it really hard to engage. I talked about kind of engaging those community partners and the challenges with that. And again, going back to the healthcare providers, they want that CDC, like, where's the document where the CDC tells me I should do this? Like, if that doesn't exist, then I don't trust what you're telling me right now. So having, some backup of, here's your clinical evidence. This is why we should be doing this. This is what we've seen in other outbreaks. That was probably one of the most challenging things from a medical director standpoint, is trying to convince others outside of my organization to do certain. And then vaccine supply challenges. I don't know how many phone calls I got of people saying, oh, I heard that there's no more vaccine left for that. Well, it's possible that there were challenges within an organization ordering the vaccine, that kind of stuff, but there were not any vaccine shortages during our outbreak. It's just that they might not have been getting to the places. And then media also either helped or hindered us at times. So they were really excited whenever there was a case about a food worker, but we needed them to talk about other things regarding hepatitis A. That wasn't always a focus for them. So trying to leverage the media to be helpful rather than harmful in this scenario is a challenge. That was a real one for the outbreak. I think overall they were on our side and trying to help us, but they also had to get their news rating. So got to balance that a little bit. So one thing I included here is just, this is the usual recommendations for hepatitis A vaccination. And homelessness was added in October of 2018, so fairly recently. And then on the CDC's website, this was a big one that I used over and over again. They actually do say anyone desiring immunity against hepatitis A should be vaccinated. So I went back to this over and over again with our community healthcare providers of, just because they don't fit one of these criteria doesn't mean you can't give them the vaccine. Please, if you have the vaccine, administer it to whoever is asking you for it. And then, we had to think creatively and decide locally what we thought needed to happen. And so we did recommend for those who would come in direct contact with people who might have hepatitis A or have risk factors for hepatitis A. So the healthcare workers, we recommended early on that they get vaccinated, food service workers, because of their risk factors, not because of contact with them necessarily. And then our EMS, fire, the people who are interacting with a lot of individuals on the street, homeless service providers or workers, and then our correctional staff and recovery facility workers as well. So locally in the health department, we very quickly initiated our incident command system to try to get all hands on deck for the response. We realized that it was not going to be, a one-time set up a big vaccine event in a venue and be done with it. So we had to think creatively. We used a lot of our staff that wouldn't ordinarily have been doing this kind of work to provide administrative support. Our nurses, our food inspectors, our epidemiologists really took a brunt of the hours that were put in for the outbreak, but I don't think we would have been able to do what we did without the support of all of our health department. And then we do have a medical reserve corps locally. It's a little bit challenging because that's a volunteer corps, so we don't always have a large pool to help us, but there were a few volunteers that put an exorbitant amount of time into this. One of our public health planner's wife is a nurse practitioner who went out on the street to vaccinate people, and I think put in about 300 hours of her own time to do that. And then again, kind of thinking creatively, our lab director saying, boy, I can develop this PCR test locally. Do you think that would be useful? I mean, those things are just kind of thinking outside the box how we can address the outbreak. And I think I went through a lot of this. So provider education, kind of going back to some of the main things that I took away as a new medical director of, I need to make sure the community knows what are they looking for, what tests should they be doing, and that they should be vaccinating patients. And then we did have some issues that improved somewhat to try to get quick reporting of cases. It's never a perfect situation, but we were able to identify when there were major delays. so that we could get the reports quicker and do our contact investigations. And then correctional facilities, they wanted to do the right thing. They just didn't really have a lot of understanding of infection control processes and what they should do. And so kind of helping them to develop some processes to make sure they're not putting infectious people in a group of other people who haven't been exposed to hepatitis A already and haven't been vaccinated. And then sanitation was a big thing, particularly for the correctional facility. So they understood how to make sure that the location for everyone there. And our collaboration, I mean, we had some great partnerships in the city. I mentioned Dr. Carico before in the restaurant industry, the Homeless Coalition, our correctional facility, and the hospital system. And the pharmacies were a huge help. People were going to the pharmacies. We were able to get some of the pharmacy directors on board so that they knew what was coming their way, and they were actually even reporting their vaccine numbers to us to let us know what they were seeing throughout the city as well. So that was incredibly helpful. I think I've gone through a lot of these things here of the response to the challenges, and our reality at the health department was that we knew that this hepatitis A outbreak was going to not be good, but without the data to convince some of our partners in the community, it's challenging, and trying to help them bring them over to the dark side so that they know, like, if I don't do something now, it's going to be a lot worse. And then the question of cost versus time, right? The more people you get vaccinated quickly, the less disease you're probably going to see, the less cost you're going to have, but who's going to pay for the vaccine? The people that are administering the vaccine. Those are all challenges that we had to work through. And I already mentioned the guidelines don't have all the answers. Sometimes you just have to use common sense, but you also have to convince others to use common sense also. And again, that a lot of times for organizations, money is where, they've got to make a financial decision. And so trying to help to sell that vaccination is going to save money in the long run. It's an important part of my job. And then the other thing I know Ray and I talked about, like, are there risk factors out there that we haven't identified? I mean, it's quite possible that there's, an absolute risk factor that's floating out there and we just haven't identified. I feel like we asked the people that we interviewed so many questions, like 6 or 8 pages worth of questions. Like, surely we have left no stone unturned, but, thinking that there may be other things that are contributing to the outbreak that you can't just rest on your laurels and think that you have everything figured out.
Along those lines, did you look at places of employment? The risk group was 20 to 50, years old, and so groups like the Kentucky Health Collaborative, run by Ford, or Health Enterprise Network, which is affiliated with GLI, might have interest. And do you know anything about the employment as a risk factor?
Yeah, I don't think we saw any specific employment that we saw a large amount of numbers other than the food industry. And the good thing is Dr. Moyer and I are in regular contact with the Kentucky Health Collaborative, so they were asking for regular updates. So every month when we go to our meetings, that we were able to provide that to some of the really big employers in the city. And then that is also a venue that we were able to reach some of the insurers as well and say, hey, we need your help with this. So initially, Medicaid did not cover the hepatitis A vaccine. There was a lot of challenges with that, and we were able to get that vaccine covered. So that definitely limited people. They could only go to certain places, and that we were able to kind of overcome that barrier. So, yeah. And it's kind of to summarize all the main points here. There's this multi-state outbreak. It's mostly drug use and homelessness throughout the country. The cases are those 20 to 40s, kind of the most common age groups that we were seeing, sometimes a little bit older than that. And then that co-infection with hepatitis B and C was very common for us, and the hospitalization rates were high because of multiple factors. We had lots of challenges, both diagnostic, clinical, and then in the community, but worked together as an organization and with the community organizations to respond, and got a bunch of vaccine out there, over 100,000 vaccines. people in the community that get ready. So, yeah, so this was my little fun part there. Felt like that for about 6 months or more, I think. 9 months. What other questions do y'all have?
So I'd just like to ask, what surprised you most about this? Political surprise or administrative surprise?
There's still political surprises going on right now. So, I think to me, it was interesting. I came from a military background where I was on a base, and when there was an issue, like literally I have all my patients right there, you give them the med, you give them the vaccine, you're done in a day, right? Like, it's easy, and in this scenario to me, even just walking into this, the outbreak was declared the day after I became the medical director. I'm like, oh, great, day 2 of my new job, fabulous. And I knew instantly, I was like, oh, this is just a big ball of worms, right? This is not a simple fix, because we knew about the risk factors elsewhere. I think we were lucky to not be California and be the first ones trying to figure this out. So we at least kind of had a clue of where to start looking and where to focus our efforts. People had done the testing for us, and we just needed to figure out what kind of interventions would work that other people have tried in our community. And that was one of the things the CDC said when they came out to see what we were doing with our outbreak responses. Boy, you guys have done all this good stuff. How did you know to do that? And it was because we had a bunch of smart people that were already talking to the right folks who had already done this and said, don't do that. You're wasting your time. Try this. And, how do we do that locally with the resources that we have? So I think one thing that was a pleasant surprise is there was a lot of support across the country. No matter what other people were doing, they were very happy to drop everything and, have a call with us, talk us through things, help give us ideas on how to fix the response. I will say, like, initially, it felt like a big struggle of communications between us and the state health department. And part of that was just a geographic separation of they're in Frankfurt and they're not really seeing what is going on here and how things operate. And we actually had them come out and meet us here. And after that, and they saw what was going on, they're like, oh, now we get the challenges that you're having. So it was a learning point for me of, early on, I think that, if I go back and do it over again, I probably would have invited them out like a weekend to think, come on out and see what we got going on here and how this is working. So I don't know, Ray or Mary or Connie or Kelly, if you guys have any other comments about things that might have surprised you. I think one thing that was awesome within our health department is we have a lot of people who had nothing to do with communicable diseases or anything, and they were, a lot of them were willing to just drop everything, volunteer for shifts, and like, you know what, I know I have this work and I have to do my job, but like this is really important and I want to be a part of the effort of the city. So I was really impressed with our staff. So, yeah.
So you mentioned in the presentation that by our 2018 had reached the threshold of vaccinating 1,000.
Yeah.
Was that taking into consideration for service workers, or was it limited? The modeling was done solely on the basis of homeless people and those people.
Can you comment more on that, Ray?
I think 18,000. So
Yeah.
I would have.
Yeah.
That early on in the epidemic, also were you thinking of the food service workers being a potential source or not?
So we recognized early, our state health department actually had been the ones that had said, our food service workers, there was not a CDC recommendation to vaccinate food service workers, right? We kept coming back to that. And they had identified, when you look at the population of food service workers in Kentucky, they have a lot of these risk factors. And so that kind of got us thinking of, okay, should we look at this population? And then when the opportunity came up with Dr. Carrico and her group to kind of partner, and I think if we hadn't had that resource, it would have, I don't know that we would have done that because we wouldn't have had the resources within the health department to get the vaccine out to that population. It was quite an undertaking, and she's still doing vaccination for them. So I don't know if we hadn't had that partnership that we would have been able to reach that group. The 18,000, I am sure, is what we did at LMPHW. So in addition to that would be the food service workers and any of them who had risk factors. So
That is also on the basis of the homeless people. And
exactly. Yeah. Yeah.
the other thing is there some like a guidelines from CDC when you get the vaccines from CDC? You need to follow. You cannot just dispense it to all. It is going to restrict. Listen.
So interestingly, that has changed over the months. things were very, very restricted when we first, when we were responding initially with the outbreak. So we were only allowed to give the federally funded vaccine to individuals with homelessness, IV drug use. We kind of expanded that a little bit locally and figured they wouldn't slap our hands too bad if we kind of got those peripheral people like EMS workers, people who were working with the homeless population. But we did try to use the vaccine for the uninsured, underinsured. That recommendation has broadened. So like now I think the state is like just vaccinate anybody who wants the vaccine. But at the time, our restrictions were much more limited. And so we really leveraged, people have insurance. Insurance pays for this. The Affordable Care Act says that this is a covered benefit. So we leveraged that fact to get the healthcare systems to help contribute. We had even our own government employees. We worked with some of the local pharmacies so that they could go to the pharmacies instead of trying to come to the health department, because we're like, can't use our vaccine on you who has insurance. We need to save this for people who don't have the opportunity to get vaccinated otherwise. So that was a huge piece of the challenge of, if we just had unlimited vaccine supply, we could vaccinate anyone. This would have been easy, right? We could have vaccinated 90% of the population and not worried about the other 10%, but that just wasn't possible with the resources that we had. Yeah.
What would have been the difference had we declared it as a public health emergency? I mean, in terms of getting finances from the state.
Yeah, I think there is. I looked at this quite a bit because I was like, would this make a difference? Wouldn't it? I think there's a certain funding amount that you would be able to get money above a certain amount. So if you reach a funding threshold, you'd be able to get additional dollars for that. I don't think we ever would have spent locally what that threshold would have been. And then going back to like the mandated vaccine, if we had declared an emergency, then we would have had the ability to like do a local ordinance saying that you would mandate the vaccine. But again, with a certain population that's at risk, it's like, how do you say, oh, that vaccine's mandatory for you, but not for you? And then especially in the jail setting, like there's so many ethical implications for that. So, I think that was an option, but what didn't end up being the option that we chose. And then the other thing that came up is an ordinance for food workers to get a vaccine. So St. Louis, Missouri did this years ago. And they had a bunch of outbreaks in the 90s, and they decided that as soon as the vaccine came out, they were going to mandate that all their food workers get the vaccine. But there's not a lot of places that have that ordinance. We had a few Metro Council people who might have been willing to bring that ordinance forward, but we had the food industry on board. They were vaccinating people. So we didn't need that to push that group of people to get the vaccine. By the time we had people offering to do that, it was like, well, we already have a system in place that's getting these individuals vaccinated. So it didn't necessarily make sense to create an ordinance that we would then have to find a way to enforce that we were already getting that group vaccinated that we needed to reach. So good question, though. Yeah.
I guess I'm curious about your experiences with the Hep A outbreak in terms of the larger opioid epidemic, and if you or what you learned about the opioid epidemic from all of this, and ways, ideas for combating the opioid epidemic.
So I think we learned a few things locally is that we were really, really lucky that we had been on the front end of developing ways to respond to the opioid epidemic. So if we had not had a syringe exchange in place, we would probably still be having high numbers of cases. Like that was because we had the systems in place that we did, we were able to reach that population. So I think one thing that is still very, very evident to me, even within our health department, we deal with people who are using drugs all the time, but stigma is such a high issue. And that's one thing that, we really need to address, especially in our healthcare system. People show up to the hospital, they want to get help. They're not there, they're there because they're sick. And, when they're treated poorly, then they don't want to go back to the healthcare system, even though they need that connection in order to ever be able to treat their addiction, their substance use disorder. And so finding a bridge there. So with our syringe exchange, we have a lot of, harm reduction techniques. It's not just about providing people with needles. It's about establishing a relationship with someone, showing them that they're valued, and trying to reduce some of that stigma that people experience. So I think for me personally, that's one of the things that I recognize that I saw a lot of in the healthcare world. But I think I'm much better able to articulate what goes on and how we can actually change that with being kinder to people who use drugs. I don't know too many people who use a Percocet for the first time and say, we hope that I become addicted to heroin at some point in my life. So, if we can start treating opioid addiction as a disease and not as a personal failing, then we'll be doing a lot better. So, yeah. Yep.
Lauren, how many cases of HIV went out?
I don't know that. I don't think that we uncovered a lot. Hepatitis C, obviously, we became quite aware, and I think we already knew this, that the numbers of hepatitis C cases in particular are so high that our community is having a really hard time even figuring out how to address those high numbers, especially in populations that are hard to risk and people who are using drugs. And, insurance companies don't want to pay for people to get treatment, but we know that if we treat them and they're sharing needles, that they're much less likely to spread that to the next person. So there's still, just a lot of, I don't even want to say indecision, just a lot of confusion about, how do you address this issue as a whole, not one piece of it at a time. So
You mentioned lack of evidence of transmission through service. That was the experience as well. Southeast Michigan, Utah.
I don't know if you know that.
San Diego currently adopted piece us through that. So what they did was kind of analyze the epidemiological risk factors for the patient and then look at the environmental component and kind of assess that completely. For them, they really had a really obvious, like they pointed out, was they have to have a really obvious failing on their end, as in something that they either observed directly or the restaurant history had checkered in order to do that. We really couldn't find evidence of that. Good our environmental work on educating the service workers ahead of time.
And I think I would compare what the CDC's kind of commentary on the food service worker piece to an accident change. So in the military, we did mishap investigations for airplanes. So like you have to have like multiple holes along the way. Like one thing happens, another thing happens. Like all these things have to align in order to have that proven transmission. And so you have to have like a patient with diarrhea. They have to be working. They have to be handling the food with bare hands, and they have to be handling food that isn't going to be cooked after they've handled. I mean, just all these layers in order to really be able to make that case that's been transmitted that way. So, yeah.
One last question. Did Indiana give anyone a heads up the issue of travel last year?
We definitely did not get a heads up. I don't know that the state health department did either. So there was some bad feelings about that, I think, initially, but and then I think within a month of that, the state health commissioner had said everyone in Kentucky should get vaccinated without risk factors even, and so I think they were a little bit upset about that at first, and then they were like, what the heck now? We just may as well tell them to get vaccinated. So, but I know I personally did not have any heads up on that. I was like, oh great, now everybody put this in there. So. I think my parents saw that in Michigan and were like, oh, so everyone has to, you guys are now a developing country, huh? So, yeah.
But no impact that was seen on visitors from Derby.
I don't think so. I think we had just as many crazy Derby visitors as we always do. So, and hotels looked solid, and I don't think we had any decline because of the hepatitis A outbreak. So, yeah. But we're not worried about catching hepatitis A at Derby. So, any other questions?
Well, thank you very much, Lauren.
Thank you all. Yeah, I know there's some other slides in there, but it's more just pictures. So.